So our next speaker is Shelby Yasesko. Uh, yeah. Okay. All right. Oof. Yeah. A lot of consonants. She is a registered dietitian, advanced practice registered dietitian, specializes in complex gastrointestinal conditions. She leads the Nutrition for Safer Surgeries program at UCLA Health, and she's an incredibly valued team member of the UCLA Aggie Hirschberg Center for Pancreatic Diseases, where she's helped so many of our patients with their nutritional and dietary needs. She's going to talk about nutrition for pancreatic cancer today, and specifically focus on pancreatic enzyme education. She's an outstanding speaker, so you're going to enjoy this. Thanks, Shelby.
All right. Hi, everyone. My name is Shelby Yasesko, and thank you for the kind introduction. I know you all have full bellies right now, so if you need to get up, stretch, move around, I'm all for it, but we'll go ahead and dive in. Okay. So briefly, our agenda for today, I do want to go over what I'd like to call my pancreatic cancer nutrition checklist. So it's just kind of a nice all-encompassing couple of areas of focus that we'll talk through today. We'll talk about some specific nutrition considerations in pancreatic cancer. I think we can't talk about nutrition without understanding what the pancreas does and its function. So we'll briefly touch on that. And we will focus majority of our talk today on pancreatic insufficiency, specifically exocrine insufficiency, which you'll learn more about. So this is my 12-point checklist. Some of you may have seen this. This may be familiar from some of our visits, but these are some of the points I like to go over. Nutrition is a very broad topic, and you go online and you'll go down a rabbit hole, I promise you. So I really try to keep things a little bit more focused so we can do goal setting together. So number one, we really want to focus on maintaining and monitoring not only our body weight, but also our muscle mass, so how strong we are throughout the duration of our cancer care continuum. We talk a lot about hydration and making sure that we're meeting hydration goals. Eating small, frequent meals. This may mean very different things, or very different things to very different people, such that sometimes I've had patients come and describe eating 1 or 2 meals a day. So we may focus on increasing the amount of food and kind of distributing it throughout the daytime, so you're able to get enough nutrients to really support and fuel your body to allow some recovery. High protein foods with our meal times, so kind of identifying what are protein foods first off, where do we get protein from, and how can we distribute that throughout the day, so that way we can continue to what's called muscle protein synthesis, or hitting those muscles to allow them to start rebuilding so we can stay stronger. We want to consider the use of different things like smoothies or protein shakes or liquid meals, which can allow us to feel less full rather than something like a solid meal that may have a lot of fiber in it. So if we're struggling with appetite or we're struggling to get enough nutrients, liquid meals can be very supportive and helpful. Choosing foods that are easier to digest. Sometimes we want to really focus on the most healthful or nutrient-dense foods, and that's fantastic. But there's also a time and place for those foods in the diet pattern if we're really struggling with getting in enough nutrients overall or enough energy to fuel our bodies. Choosing essential whole grain foods and foods that are very colorful. So I challenge all of you for spend a couple of days and look at the color of the foods that you eat. It's kind of fun to do. It's a little homework assignment. If you're eating all green foods, or if you're eating mostly all purple or blue foods, I challenge you to try to eat the rainbow. Not necessarily eating a whole bag of Skittles, but eating the colors of Skittles is a good way to kind of phrase it. Looking at what could be considered more of a healthy fat or more of an anti-inflammatory fat versus fats that we may consider more pro-inflammatory, or they may lead to increase in inflammation in the body over time. Limiting sweets and added sugars. So again, dialing back to can we focus on some of those more complex-based carbohydrates that we know feed the bacteria in our guts over time properly. Watching for changes in our bowel movements, and this goes back to the exocrine insufficiency that we'll talk about, and staying active. Do what you love and enjoy to do by moving your bodies. Sometimes we get really wrapped up and say, I don't have a gym pass. There's a lot of ways we can stay strong and active just by doing things that are, generally outdoors or even chair exercises. So using what limitations and functional capacity we have to its fullest so we can keep challenging our bodies to stay strong and recover. So this is just a nice little snippet in a overview. I know Dr. Herman earlier mentioned about the prevalence of malnutrition in pancreatic cancer, and it's quite alarming. We look at the research, and realistically anywhere up until about 90% we see cited in some of the studies of patients who have different degrees of malnutrition, whether that be more mild, moderate, or severe malnutrition cases. But there's a number of different factors that can lead to this. So inflammation of the tissues in the body, changes in metabolism that can happen with a cancer diagnosis, oral intake or the reduction of oral intake or how much we're eating, exocrine pancreatic insufficiency or EPI, which is what we'll focus on today, micronutrients and how well we're absorbing some of these vitamins and minerals that we're taking in through our diet and our food, as well as motility changes, meaning how well is food moving through the GI tract and allowing it to absorb properly. So this is kind of a nice little snippet here, but I like to, again, allow everyone to understand what is the pancreas. So if you have not seen it, this is a nice little overview of the 3 sections or the main sections of our pancreas, with our head in that kind of pink or purple, the bluish teal color being more of that body, and then we've got more of our tail in that yellow side. And why I like individuals or anyone to really understand what the pancreas does is because when there's a tumor, there's a resection to the pancreas in these different areas. It helps me as a clinician and your other team members kind of be able to forecast or understand a little bit more as far as what symptoms or what potential other signs or symptoms you may start experiencing, things like exocrine pancreatic insufficiency or diabetes related to a pancreatic surgery or resection. So when we start losing function or we change the structure to the pancreas, it allows both you as patients or caregivers or us as clinicians to better understand and support your care management. So we've got 2 kind of main functions of the pancreas here, our exocrine functions and our endocrine functions. So just kind of differentiating or describing the difference between these 2 here. Our endocrine functions, the main one I want us to really focus on today, and I've got one slide just briefly on this, is the production of insulin. So a lot of you may have heard the term insulin before. And what insulin really does is it helps to lower our blood sugars by using the sugars that we get from food or the carbohydrates that we eat for energy. So it helps drive in those floating sugars into cells so we can use it for energy. And then we've got our exocrine functions, which is that secretion of the digestive enzymes, ions, and water. Primarily, we'll talk about the digestive enzymes today. So briefly on endocrine functions, you may have heard the term type 3C diabetes. If you haven't, I'm happy to kind of introduce this concept to you. It's unfortunately often misdiagnosed and underrecognized, but it can develop when the pancreas stops producing enough insulin, or it can happen when a condition affects or damages the pancreas, or even after things like a pancreatic surgery where we're taking out part of the pancreas in entirety. The worldwide prevalence is unknown. You see a lot of different numbers in our research and our publications, but we do know it's often misdiagnosed and it's often underrecognized, unfortunately. There's really not a universally accepted diagnostic criteria, but there are different criteria out there that providers such as an endocrinologist may use when having a diagnosis of this. And management can depend on the level of damage and cause, but may include things like oral medications, the use of insulin, diet and lifestyle medications. I want to, emphasize in the course of this lecture that there's no single food that's going to supply all the needs the nutrient needs that we need for our bodies. So good nutrition means incorporating a variety of foods. So EPI, what is it? Some of you may have heard this here, exocrine pancreatic insufficiency. So EPI is a condition caused essentially by the inadequate delivery, production, or activity of pancreatic enzymes needed for normal digestion. So we're not producing enough, it's not mixing properly with food, or there's something going on with the activation of the enzymes, if you will. So our three main pancreatic enzymes, and any of you who are on a prescription pancreatic enzyme, if you look at your bottle, you're actually going to see these words on here. So lipase, protease, and amylase. And what these three pancreatic enzymes are, they help us break down our proteins, our fats, and our carbohydrates. We know that fat tends to be the macronutrient, or one of our main nutrients that can cause the most symptoms or gastrointestinal symptoms when we eat. And that's that lipase dose. So when your care team prescribes a pancreatic enzyme medication, we often kind of do our titration and dosing based on the lipase units or that fat digestion. And we'll talk about that in a minute. But unfortunately, diagnosing EPI is very difficult, and I'll show you why in just a second. Because a lot of the signs and symptoms that may be presenting, or somebody comes and describes some of their symptoms, can also mean, unfortunately, a variety of other things. So we really have to think through when we're looking at an EPI diagnosis and understand the person a little bit more before we just jump to a conclusion. EPI is seen in other disease states outside of pancreatic cancer, and it can be transient, can present in more mild forms. It may, present in ways that we initially may have thought, but then later maybe we don't think as much anymore as far as an EPI diagnosis. But the testing for EPI is somewhat limited, and I will describe that in just a moment. So these are some of the signs and symptoms, and again, it can be quite subjective. But that's why it's important to bring what you're experiencing to your medical team so we can really go through to better understand your symptoms and if these things are being associated with food and how they're impacting your quality of life. So as part of our Canopy Cancer Collective dietitian group, we've worked together among the different sites to kind of put together what we know about our own clinical experience, but also what the literature shows can be suggestive of an EPI diagnosis. You can see a lot of these, can be quite subjective, and there's a lot of different signs and symptoms on this list, which is why I spend a good portion of the time with my patients and individuals I work with going through to understand, how often are we experiencing some of these things? Are your symptoms associated with certain meals versus other meals less so? Does the amount you eat matter? The time of the day make a difference for you? So there's a lot of things we really want to consider when we're thinking through an EPI diagnosis. And I'll show you the prevalence of EPI and pancreatic cancer in just a moment. So some testing considerations. Based on our guidelines, which I'll show you in a moment, it is suggested that with metastatic pancreatic cancer that we do an enzyme trial without necessarily testing or quote-unquote confirming a potential diagnosis of EPI due to the prevalence we see in metastatic pancreatic cancer. But FE1 is essentially the production of elastase that happens from our pancreas, and it helps give us a rough idea if pancreatic insufficiency may be present. We know somebody who has more significant or severe pancreatic insufficiency, the stool testing or that fecal elastase test is more sensitive. So we see it, upwards in the 80 or so percent being a little bit more sensitive. Somebody who has a more mild pancreatic insufficiency form, the stool testing is a little bit less sensitive, typically in the 60 to 70%. And essentially what a fecal elastase test is, it's a one-time stool sample. And again, we're measuring the elastase production from the pancreas. In our practice, a lot of times in our IPU clinic, as well as within our health system, we will look at doing a prescription enzyme trial if we do think and you are presenting with pancreatic insufficiency symptoms, to see if we can help support you to ensure that you're absorbing and digesting your food properly. So there's a little bit on the back end and the science of it that we have to think through. These are the UK practical guidelines from 2021. So this is kind of one of the newer consensus for the management of pancreatic exocrine insufficiency. And what's nice about these particular consensus guidelines is they do give us an idea as far as the different types of pancreatic cancer and when testing may or may not be recommended prior to starting a prescription pancreatic enzyme replacement therapy medication. So this helps kind of guide us as clinicians of what to do in certain cases. As far as our NCCN, I know you've heard that term a couple of times. That's the National Comprehensive Cancer Network, guidelines for patients with pancreatic cancer, and this is from the 2021 excerpt. Deficiency in pancreatic enzymes results in inadequate absorption of our fat, carbohydrates, and protein. That should ring a bell from the lipase, amylase, and protease we talked about, leading to steatorrhea, which is really this kind of typically foul-smelling, oily, greasy, floating stools that can be kind of urgent in nature. We've got to run to the toilet after we have a mealtime, really due to that kind of malabsorption that's happening. Often we see a kind of yellow or tan-colored stool in this steatorrhea picture. Also abdominal cramps, weight loss, and malnutrition. Because pancreatic exocrine insufficiency occurs in up to 94% of patients undergoing pancreatic surgery or resection of the pancreas, therapy may be initiated without testing. So this kind of aligns very similarly with the UK 2021, where certain populations we may prescribe pancreatic enzyme replacement therapy if you come to the office and are describing symptoms that are consistent with it. Because pain and malnutrition are also prevalent in patients with pancreatic cancer, the panel recommends that patients with locally advanced or metastatic pancreatic cancer receive a nutritional evaluation with a registered dietitian. So I think at UCLA, we've made a lot of really awesome movement with our Canopy Collective network, as well as the Hirschberg Foundation, to allow access to a registered dietitian, which is me. We're hoping to continue to keep growing this program out because we strongly do believe that the recognition of nutrition, the recognition of malnutrition, and the recognition of things like endocrine insufficiency and exocrine insufficiency, where our blood sugars are not well controlled or we're not really properly digesting and absorbing our food, that can be very devastating and that can be very impactful to somebody's quality of life. As well as how well perhaps they're able to tolerate their treatment or move on to their next step. So we do recognize that here at UCLA Health, and we want to continue to support as many patients as possible through their cancer continuum. And this is just a quick snapshot of the Hirschberg Foundation nutrition page. If you haven't visited it, please go see it. They've got some great resources. There's also a blog that's written on EPI if you'd like some more information. And thank you so much. I'll stay up for questions. I must have covered the topic so well.
Good question. Really great talk. I was just curious here, at UCLA, you guys really have done such an incredible job integrating nutrition, wellness, as well as exercise programs. Yep. What could you potentially, like if you were to sort of replicate what you guys are doing here at other centers, do you have ideas on how to educate, sort of integrating those together? I think a lot of times they tend to be separated. Yep. And I think if everybody does what you guys are doing, I think it would be an awesome program.
Yeah, thank you. So I'm a strong believer that nutrition should be talked about from day one of diagnosis. It's going to impact things as far as food safety principle goes. If we're going to any kind of cancer treatment, whether that's neoadjuvant treatment or we're going to chemotherapy or radiation, nutrition can be impacted. Malnutrition is through the whole trajectory. So if you do not have access to nutrition services, Please ask, and advocate for yourself so you can get access to that. You would be surprised, a lot of insurances more and more continuing to cover services with a registered dietitian. There's new even lifestyle supplemental accounts on a lot of insurances coming out that do provide access to registered dietitians if it's not within your actual plan itself. So it's important too that dietitians are very much like any other healthcare professional where we have training in certain areas. So finding a registered dietitian that has a subspecialty or is trained in GI care is very important. So you can get the expertise that you need and deserve in order to help guide your care plan. And another thing I didn't even get a chance to talk about today, I have a huge passion for exercise and movement. So that also really is not stressed enough in our cancer centers. So please continue to move your bodies, figure out ways you can stay strong, look into getting physical therapists if that's something that you think would be helpful, or an exercise physiologist that may be available to you through the cancer center. If we don't nourish our bodies, we don't move our bodies slow down. That's not rocket science. You don't need me to tell you that. But sometimes we get into the mix of everything going on with the cancer itself, but we forget about the whole person in the body, and that the body needs food, fuel, and movement to keep going.
We're often told that like sugar is bad, but complex carbohydrates are okay. But since carbohydrates are broken down immediately by the amylase to sugar components anyway, that doesn't sound logical.
Yeah, that's a good question. So I'm happy to kind of debunk the concept of sugar feeds cancer briefly. This could go down a rabbit hole too. Sugar feeds all cells in the body, whether it's complex or simple. It's going to at some point turn into similar structures. However, the thought is behind there are some sugars, like added sugars and more simple or refined sugars, that may have more pro-inflammatory effects to the body. So it's not that you can't eat sugar, that reducing your simple sugars will starve your tumor, will kill the cancer cells. Unfortunately, we don't see that relationship. But the goal is that we're giving our body, I like to think of it like premium gas in our gas tank. So most of the time, we're choosing foods and fluids that give us good nourishment and good nutrients. When we choose foods that are more unrefined or more whole, we're going to get other compounds, plant compounds, vitamins, and minerals. When we're choosing a lot of refined carbohydrates or added sugars, they tend to have less nutrients as a whole in that food or fluid. So think of it in perspective of how often we're doing these things and what it's giving our body from a nourishment respect.
I've got a lot of questions from our online viewers. First, what about an anti-inflammatory diet in general?
Yeah, and if you go back to the research, there's no one anti-inflammatory diet. We get a whole lot of different thoughts and opinions and diet patterns, but I like to think of it as, and what our American Cancer Society recommends, is that we're consuming 5 fruits and vegetables, non-starchy vegetables per day, so we're getting in enough plant compounds that help promote anti-inflammation in the body. So I like to, when I work with patients, a lot of times we'll set like fruit and veggie goals together, and some being easier to digest versus harder to digest. So don't feel pressured that you've got to get those most cruciferous leafies as possible, because that may not make sense for you right now, but we can still look at other options to get in good compounds.
Does the tail position of the tumor in a metastatic patient make a difference in the prevalence of EPI?
Yeah, that's a good question. And it's hard because we give our best guess as far as those who may have EPI and those who don't, and there's not always a rhyme or reason. But for the most part, it's very tough for us to know really what the function of the cells are from the pancreas and how well they're working. So when we're looking at an EPI diagnosis, I ask you a whole lot of questions. Sometimes it's probably annoying, and I recognize that, but it's helping me and the care team collect data to understand if EPI is something that's on the table or if it's something else that we need to consider, given your symptoms.
My question Is this working? Yeah.
Yes, I can
My
hear you.
question has to do with people who don't live in Los Angeles, and I am about 2 hours away from Los Angeles, and I'm a long-term survivor, and I have had some version of EPI for a long time, but I've gone to the local cancer center, which is wonderful, but it isn't UCLA, and it isn't Los Angeles, and there is a nutritionist there that I've consulted with, but she is covered by a particular grant and can only deal with those people who are currently in treatment. So she was quite willing to just help me a little bit, but what do you do when you're out of town? Because you've mentioned a whole lot of stuff that I'm aware of, but there's nobody to help diagnose this particular case.
Yeah, and I think going back to even the navigator conversation, I think centers are recognizing more and more the value of having supportive care services. And, you know, we used to just focus on really the medical oncology, radiation oncology, and surgery side, but some of these other disciplines got forgotten a little bit about along the way. So my recommendation would be to continue to see, you know, within your insurance network of who may be available for you to see, whether that be virtual. I do consultations throughout our whole UCLA health system, and even outside, I've had a number of patients come to me. And so each center is set up a little bit differently with their nutrition or dietitian services. But I know myself, I offer a lot of virtual visits for patients all over California. So that doesn't necessarily mean you can't see a provider at an institution if they do offer services. So my recommendation would be just to reach out and ask. And
Thank you.
if that person, they might be able to refer you to somebody that you can see too.
Thank you.
Of course.
Resources on using Creon.
What kind of resources? Just resources in general. So there's different enzyme brands. So kind of outside of that, essentially, you know, having a conversation with your provider about your diet pattern, because people may need different amounts of enzymes at different meals and snacks. And the timing may be a little bit different for a different individual based on their symptoms. So resources being, you can look at, you know, the company or the pharmaceutical company that you're getting the medication from and look at their patient resources on their website, which can be very, very helpful. But also checking in with your healthcare team and your provider to figure out the best way for you to take the prescription medication that's going to make sense for you, because people are a little bit different. Somebody who eats 2 big meals a day is going to look very different than 5 or 6 small meals a day with liquids in it.
How much protein do you typically recommend for patients with EPI?
Yeah, so it goes back to how well we're absorbing. So we can have EPI and it's well treated and our symptoms are well controlled, and I feel confident that the patient or individual is absorbing their nutrients pretty well, or somebody who's a little bit less controlled and we're having trouble really getting the absorption of those nutrients. So somebody who's having a lot of malabsorption or active weight loss, we're going to need to up titrate their protein and calories to support them at that time.
So it's not one number.
Not one
Not
number.
one size
I
fits
wish
all.
it was that easy.
Can you share any thoughts about the possible efficacy of a fast mimicking diet before and after to make chemo more effective and less harsh on healthy cells?
Sure. Fasting is obviously a very hot topic in the cancer care research. Unfortunately, realistically, we're not there yet. I don't recommend fasting, especially in patients who have active malnutrition or are losing weight, because that reduces our eating opportunities. So malnutrition, unfortunately, is something that it can be very devastating and lead to a lot of complications. So if you are malnourished or you have a loved one that's malnourished, that should be a priority in treating that, rather than perhaps practicing a diet pattern that we just don't yet have really robust science behind it being supportive to care.
I have a question about probiotics, and I know there was discussion about the microbiome. And I did have a consultation with a naturopath, oncology naturopath, and she recommended a probiotic. And I know, I guess there's anti-inflammatory processes that can happen with probiotics. So what is your take on that?
Yeah, that's a really good question. So every single person in here has a different, what's called a microbiome or flora of their gut, meaning you have different species, different amounts of those species that live in your gut. So the answer is I don't know what species you have and how many you have. So when we give probiotics, we're giving a large volume or CFUs or what's called colony forming units of different strains into the gut without really knowing what's already in your gut right now. So the short answer is we don't know what type of probiotic, how many strains, what brands. There's thousands and thousands of companies out there that sell. So right now we just don't have the evidence to support how to best give probiotics in a fashion that's going to be helpful to somebody's care journey.
It's great. Thank you, Shelby. Your last answer is great because I really don't like kombucha myself.